thank you for that very kind and overly generous introduction. I'm certain that if my parents were here, they would be blushing even more than I am. That was very, very kind. And also, of course, thanks to the organizing committee, Professor Mizrahi, for arranging this opportunity for me to share with you some thoughts about this very interesting and challenging disease. So I would start by just saying greetings from the MD Anderson Cancer Center in Houston, Texas, which is where I work. A couple of general observations about soft tissue sarcoma. It's a very rare tumor, less than 1% of adult solid malignancies, and it consists of a complicated group of subtypes, over 50 different histologic variants. There's much intratumoral heterogeneity, which has a role in its biology. They can occur throughout the body, anywhere where there's connective tissue. 80% of the relapses in these patients occur within 2 years of the initial treatment and diagnosis. 80% of the metastases are pulmonary. If the patient does develop pulmonary disease, the 5-year survival rate after successful metastaticectomy is about 35%. So in summary, it's a rare orphan illness, and very little is known about the underlying molecular determinants, which is going to be important if we're to advance our understanding and therefore our therapy of this disease. Now, there's a number of problems in the clinical management of soft tissue sarcoma, among which are an approximate 40% discordancy in assigning underlying histologic subtype or establishing the grade, even among expert sarcoma pathologists. There are several non-interchangeable staging systems that are in use throughout the world, which make it very difficult to compare results from one series to another or even across time in the same center. There have been no essentially new therapies developed in this disease since the early 1970s. The surgery at times can be very debilitating. The response rate to chemotherapy is modest, to say the least. Radiation does have a role, but like most radiotherapies, it's expensive and inconvenient. And the overall survival rate of 50% has been stagnant for nearly half a century. Tremendous opportunities for improvement. So these persist as the key challenges in this disease. What are the clinically resistant questions? Can we identify them? What will be the research strategies to get the answers? And how can we apply this information to help patients? We've learned many lessons in caring for patients with this disease over the past quarter century. First of all, sarcomas can be either pushing or infiltrative. Here you can see a sarcoma, malignant fibrocystiocytoma, eroding right through the wing of the ileum. This is a retroperitoneal liposarcoma, and you can see that it's pushing the entire root of the colonic mesentery anteriorly. And you can also see this radiologically, a pushing lesion above where there's a plane between the tumor and the pelvic girdle, as compared to this infiltrative lesion, which is going right across the chest wall and about to fungate out through the skin. The tumors can be very heterogeneous. This is a large, well-differentiated liposarcoma, and within the liposarcoma are two foci of dedifferentiation. Here's a needle biopsy being performed of one of them. These dedifferentiated areas behave in a much more aggressive biological manner than the rest of the well-differentiated tumor, and so being aware of these issues of heterogeneity become extremely important in planning a therapeutic approach. Sarcomas can be locally invasive. They can be very locally destructive. Here's a sarcoma that is engulfing the sciatic nerve, and it's no longer a conductive neurological structure. They can be very locally recurrent. A patient with 13 procedures that we have performed for a desmoid tumor of the pelvic girdle. They can be extremely angiogenic, a leiomyosarcoma of the small intestine, and you can see the neovascularity in the tumor very clearly. As I mentioned, these disseminate to the lungs, and this dissemination can be very rapid. A patient from my practice before surgery, and 3 weeks later, already 3 metastases have shown up. Local control can be very costly. A large malignant fibrous histiocytoma of the posterior thigh, engulfing the sciatic nerve, where to get control of the tumor, the nerve had to be sectioned. Diagnostic images are not always accurate. An example of that finding is this patient with a large intra-abdominal and retroperitoneal tumor crossing the midline, appears ominous, doesn't appear to have a plane of dissection between the tumor and the rectus muscle sheath here. But at the time of surgery, unlike what the scan suggests, the tumor itself is attached by a very small neck of tissue to the gastric area, and that could just be resected with a simple stapling maneuver. How the biopsy is performed is critical to outcome. An example of a poor biopsy here, you can see this cross-shaped incision performed prior to the patient being referred to our center, a small synovial sarcoma of the patellar tendon. The biopsy site is infected. Unfortunately, at the time that this biopsy was performed, somehow tumor was intruded into the joint space, and what should have been a simple local excision became ultimately an above-knee amputation. In contrast, a patient referred to us de novo with a tumor in the same essential area. The biopsy scar is oriented parallel to the long axis of the extremity, and at the time of the definitive excision, the scar, underlying tissue, can be removed en bloc with the tumor itself. Tumor biology can sometimes be your friend. This is an example, one patient with a myxoid malignant fibrous histiocytoma wedged in between the scapula and the brachial plexus. The myxoid tumors tend not to be metastatic, they tend to be locally recurrent, and so a decision was made to remove the tumor rather than perform a 4-quarter amputation. About a decade later, the patient did finally fail, and that required a 4-quarter chest wall surgery, as you can see here, but in the meantime, this patient had their arm as a bioprosthesis on loan for an additional 10 years of useful living. Sometimes radical surgery can be life-saving. On the other hand, sometimes judicious palliative radical surgery can be important in prolonging life. This is a patient with a very large grade 1 chondrosarcoma of the retroperitoneum, retrohepatic space, and you can see here that this tumor has eroded through the chest wall. There's no margin to be had on the vertebral body, so this will be a gross total excision if it's performed. On the other hand, it's a grade 1 chondrosarcoma. This is a surgical problem because these patients will recur locally. The decision was made because of the biology of the disease, knowing that chondrosarcomas, as they recur, will frequently recur in higher grade and require chemotherapy. So at the time of resection, a deliberate decision is made to save the kidney, as you can see reflected off the tumor, while excising the tumor, knowing that this patient may need 2 kidneys later on to receive ifosfamide chemotherapy in the event that the patient fails. And this is the completed resection. Sometimes judicious palliative limited surgery can also improve the quality of life. This patient with a recurrent dermatofibrosarcoma protuberans referred to me after a total sternectomy. And you can see these areas, we were very concerned. The patient did have lung disease. Rather than doing a more extensive full-thickness chest wall resection, serial local excisions was an excellent palliation for this individual. The best outcomes are achieved by multidisciplinary specialist teams working together, evaluating the patients prior to any binding decisions being made. This is our experience in soft tissue sarcoma, unpublished data comparing our results by stage to those of the National Cancer Database in the United States, which accessions 80% of the solid tumor resections performed. And you can see stage for stage, the ability of multi-specialist teams working together directly impacts on survivorship. In order to accomplish this, we believe very, very strongly in the multidisciplinary planning conference, as is shown here in this picture. This is actually a picture, an artist's depiction of the Sanhedrin from the early 1800s, a French artist. Why is the multidisciplinary conference important? For a number of reasons. First of all, it enables you to formalize and structure discussions about patient care issues, and in doing that, it diminishes the impact of modality-specific bias and anecdotal information. It enables everyone who's going to be involved to look at the evidence collectively and decide, is this level 1 evidence or is it of less quality than that? Assess the underlying strength of the data. It gives you an opportunity to assess whether or not a patient is eligible for a clinical trial prospectively. You can also enroll these patients in databases at the time of their initial presentation. And certainly, as a practical matter, it facilitates consultative scheduling. In order for the conference to work, the attitude of the individuals in the conference has to be typified by flexibility and collegiality, openness, and lack of ego. Opinions are solicited before rather than after irreversible steps are taken. It creates dialogue in a nutshell. For the surgeon participating in the sarcoma multidisciplinary conference, it enables you to articulate several of the important principles, particularly to those other individuals in the conference who may not be as aware of some of the surgical issues that we have to deal with in this disease. Therefore, before surgery, it's critical to understand the natural history of the disease, to get imaging before biopsy because of the problems with biopsy artifact that might be confused with a disease presentation. The biopsy has to be planned with the ultimate resection in mind. As an example, the patient who didn't have that done with that cross-shaped incision by the patellar tendon. The patients have to be adequately staged so that the appropriate sequence of therapies can be decided upon up front, and any reconstructive maneuvers have to be discussed and planned for at the same time. During surgery, it's critical to create an incision that has adequate exposure so that you can deal with the underlying tumor problems as well as preserve the critical structures. Those have to be identified and controlled. Margins have to be delineated. It's our obligation to provide the patient with an en bloc resection of all gross tumor, including adherent structures if needed. And then we make very extensive use of frozen section analysis to control our margins to be certain that at the time of the completion of the operation that we are satisfied that we've done the very best by way of doing a gross total excision with negative margins. Some of these principles I can illustrate with two different examples of patients who have tumors in the proximal thigh and pelvic girdle area. This is a lady who has a very, very large synovial sarcoma. Just to orient you, this is the anterior superior iliac spine, this is the buttock, and this entire tumor, which occupies most of her thigh, is the problem. She was receiving 1,200 milligrams of morphine a day. This was not controlling her pain. She was unable to get out of bed and interact with her family, and so a decision was made to undertake an operation, a hemipelvectomy, in order to get tumor control. So at the start of this operation, it's very important to identify and control the critical anatomy. We begin with an iliac fossa exploration to identify the critical vascular and urologic structures, as you can see here. When we're performing this operation, we divide the iliac vasculature not at the level of the common iliac artery, as is seen in many textbooks. Instead, we try to preserve that and divide distal to the bifurcation, and that has a very important consequence, which is that you can preserve the first branch off the iliac here. You can see the superior gluteal artery going down in through the sciatic notch, and that enables you to preserve vasculature to the gluteus musculature so that the padding in the resultant flap is much more robust and won't erode through. The obligation is to provide an en bloc resection, and so this has been performed. Here you can see the tumor pushing up. This is the symphysis pubis, which is divided as the medial margin and posteriorly the sacroiliac joint, and then the reconstruction as is shown. And this is why it's so important to preserve the superior gluteal artery. Otherwise, you just have a a pad from the posterior aspect that consists of skin and underlying fat tissue instead of a very well-thick, vascularized myocutaneous flap. Now, another patient referred to me for consideration of a hemipelvectomy. Again, same tumor area, although obviously this tumor is not quite as big. And this will point to the ability to understand the natural history of the disease as well as how to connect other modalities in the treatment. This individual, and you can see the tumor here, had suffered 3 recurrences of this tumor prior to referral. Interestingly, the individual was both chemotherapy as well as radiation therapy naive, a fact that came out promptly at the multidisciplinary conference. And so a decision was made, rather than to perform the hemipelvectomy that the patient was referred to us for consideration, to use neoadjuvant treatment strategies first in an attempt to either stabilize or cytoreduce the tumor, and then see if a salvage situation was possible. So this is the patient after neoadjuvant therapy. The tumor itself did not shrink in size, although I will show you some interesting histologic findings in a moment to suggest that this approach was effective. You can see here the adequacy of the excision that's needed and the scars from the previous operations performed elsewhere. Because of where the tumor is located, it's our obligation to remove the tumor with surrounding normal tissues to get a negative margin, and in doing that, it requires us to do a full thickness excision of the entire groin and abdominal musculature. So here's the patient after the excision has been performed. The psoas muscle can be seen here, and here's the basically the aortic bifurcation. The inguinal ligament would have been in this area here, and so this is the entire iliofemoral system dissected out from the tumor. Thinking about reconstruction in advance, at this point our reconstructive surgery colleagues will come into the operating room, and they're making a new inguinal ligament here out of Gore-Tex, which you can see. Sometimes in doing these cases, if there's vascular involvement, that also has to be accounted for, and so the vascular surgery team will also work with us as a 3 or a 4 specialty approach to a complicated tumor situation. In this individual, a vascular resection was not needed. Here's the neo-inguinal ligament in place, and then this will be covered by a rectus flap from the opposite side of the abdomen. And this is a patient who came to us, referred for a radical amputation, who walks out of the hospital intact and has been free of disease since 1994 because of a judicious application of neoadjuvant strategies that are coupled with a thorough understanding of the biology of the disease. So what is the role of non-surgical therapies in soft tissue sarcoma? As I mentioned, the most effective sarcoma surgery is based on a thorough understanding of the strengths and the weaknesses of the non-surgical therapies, and how to integrate these therapies vis-a-vis the surgical approaches is critical to the overall success of patient care in this disease. Let's talk for a moment about radiation therapy. Radiotherapy can be given as external beam or as an implantable catheters. The external beam can be delivered either as a preoperative treatment or a postoperative treatment. There are advantages to both. The preoperative radiotherapy fields tend to be smaller, and certainly if cytoreduction is achieved, it might be possible to preserve some structures that otherwise would be at risk had they needed to be resected in advance of a postoperative treatment. There's no delay in the start of radiotherapy, which of course the radiation oncologists are thrilled by. And at least theoretically, there's less chance of wound implants being discharged at the time of surgery or tumor embolization into the lymphovenous circulation that might happen as the tumor is manipulated. Now, postoperative radiotherapy also has some remarkable advantages. For the patient, there's no delay in the surgery, and that can be very, very important if someone has intractable pain that is being moderately managed, or a tumor that's about to fungate through the skin. Psychologically, it's much easier for the patients to go ahead and just have the tumor removed and then receive the radiation as a straight adjuvant. You avoid the significant radiation-induced wound problems, which in some series approximates 30 to 40% of all patients. The entire specimen is available for pathology or, in our case, laboratory analysis. And the size and the extent of the tumor can be very accurately assessed. Now, this cartoon illustrates some of the differences between preoperative and postoperative radiation. In this central area, the crosshatched area, this is the clinically detectable tumor, the tumor that you can see on a CAT scan or that you can visualize with your naked eye in the operating room. These tumors are very insidious because they do have microscopic extensions from the main tumor that are not visible to the naked eye, and those are represented by these little white dots here as tumor extensions from the main tumor. So if the radiation is given preoperatively, the radiotherapy field is this first box to encompass the tumor as well as these subclinical extensions. However, if the radiation is given postoperatively, then the outer box has to be your field because the inner box is your surgical margin and you have to give an additional boost. As a practical matter, this works out to a radiotherapy field that's about 35 to 40% larger if the radiation is given pre versus postoperatively. And the other relative disadvantage is the fact that the hypoxic surgical wound environment of the postoperative radiotherapy field means that a total dose of radiation of approximately 6,500 rads has to be given as compared to 5,000 rads to exert equivalent tumoricidal control if the radiation is given before surgery. In our center, a rad costs $3, and so in a managed environment, the difference financially is approximately $5,000. That's worthy of consideration, particularly if you're using these approaches in a high volume of patients. Now, interestingly, there's only been one prospective randomized trial to compare preoperative versus postoperative radiotherapy. This was performed by the group at the Princess Margaret Hospital now more than a decade ago. Patients were randomized to receive either 50 gray of radiotherapy pre-op versus 66 gray post-op. Because of wound complication problems, there were the pre-op arm, in the pre-op arm, the trial was closed, short of total patient accrual. However, there was sufficient power to be able to see that at 5 years of real survival time, there was no difference in either disease-free or overall survival, and the limb function was, however, markedly improved in the group that received radiotherapy preoperatively, no doubt as a function of the smaller field and the smaller dose of radiation that was required to achieve tumoricidal control. Yet another approach to radiation of soft tissue sarcoma is the use of brachytherapy, interstitial radiation. That is accomplished at the time of the tumor resection, which is shown here. Our radiation oncologists will come to the operating room, they scrub in, and these afterloading catheters are placed at very well-measured 1 centimeter intervals throughout the tumor bed. 5 days later, when a certain level of tensile strength in the wound has been reached, the afterloading catheters are loaded with iridium-192 wires. They are left in place for an additional 5 days, and then the patient and the wires and the catheters are removed and the patient is discharged from the hospital. There's some real advantages to this approach, one of which is the fact that it takes 5 days instead of 5 to 7 weeks. This can now be done as an outpatient procedure once the afterloading catheters have been loaded with their wires. The total dose of radiation is between 4,800 and 5,200 rads, and the penetrance can be very tightly controlled to be 1 centimeter or less, which is particularly important in the pediatric age group if there's a tumor near a yet-to-be sealed epiphyseal plate, or in an adult population where the tumor may be very close to the gonads in someone of reproductive age. Being able to avoid those scatter problems becomes very, very important. And as has been demonstrated a number of years ago by the group at Sloan Kettering, this type of approach is also very effective in attaining durable local control, as can be seen in this survival curve demonstrating the local control in patients who received brachytherapy as compared to those who did not. Several words about sarcoma chemotherapy. The drugs are highly toxic and the response rates, unfortunately, are quite modest. A number of the drugs that are used, most important two drugs at this time are doxorubicin and ifosfamide. As single agents, they have very poor 20 and 30% overall response rates. And for this reason, they are usually given in multi-drug combinations, which increases the response rates up to in the order of 50 to 60%. However, it's important to bear in mind that the drug toxicity, particularly the cardiotoxicity of doxorubicin, is cumulative over time, and 100% of patients exposed to the drug will develop some measure of toxic side effect. Contemporary regimens of treatment include combinations of doxorubicin and ifosfamide. A very common such combination is the so-called MAID regimen, mesna, adriamycin, which is the trade name for doxorubicin, ifosfamide, and DTIC with a growth factor. Mesna is a urothelial protector that you have to use with ifosfamide because of the problems with hemorrhagic cystitis that occur in these patients. A more recent combination, gemcitabine and Taxotere, has received quite a bit of attention, very high response rates, but the durability of those response rates and whether this translates into a survival benefit have yet to be demonstrated. Now, clearly, some patients will respond. This is an example of such an individual, a large tumor that is encasing, or at least certainly engulfing, the aorta, the renal pedicle. You can see it here. This is before chemotherapy. And after chemotherapy, there's about a 50 to 60% cytoreduction. This is this patient prior to the initiation of chemotherapy, and you can see that this is a very hypercellular malignant fibrous histiocytoma. After the chemotherapy, almost all of the cellular elements have dropped out, and the tumor has basically been rendered a scar by the use of drugs in this fashion in this fortunate patient who did respond. The response to chemotherapy may be an important correlate of survivorship, as was recently demonstrated by the UCLA group. Shown here, patients who have high percentages of tumor necrosis after neoadjuvant chemotherapy, where high percentages, 90 to 95%, do much better over time than patients who do not mount that sizable 8% necrosis. However, its use as an adjuvant as compared to a neoadjuvant remains very controversial. This is data that was presented last week at ASCO from the EORTC. 351 patients who had large, high-grade sarcomas without metastases were randomized to observation versus doxorubicin and ifosfamide in standard doses. Radiation therapy in this experience was used for patients who had a marginal resection or if they had a local recurrence. The 5-year recurrence-free survivorship in both arms was 52%, and the overall survivorship was actually a little bit higher, although not statistically significantly higher, in the observation arm as compared to the chemotherapy arm alone. So the hypothesis that chemotherapy use as an adjuvant would increase recurrence-free or overall survival was rejected. That mirrors very nicely an experience from our own group, a paper that Janice Cormier in our department published 2 years ago in the Journal of Clinical Oncology, in which she took stage 3 patients treated with chemotherapy at MD Anderson as well as at Sloan Kettering, combined both databases, and then looked at the long-term survivorship in these individuals. And interestingly, as you can see, the patients with no chemotherapy, that's the red line, in the early period, first 2 years after treatment, have a survival advantage. However, those two curves cross over, and by the time you get out to the 10th year, patients who had chemotherapy actually have done worse in terms of their long-term survivorship compared to those that did not. It's quite likely that the use of chemotherapy early eliminates chemosensitive clones of cells and therefore allows chemoresistant cells to grow out over time, which might be one explanation for this finding. Obviously, there are many major unresolved issues in the use of chemotherapy in this disease. How should neoadjuvant response be measured? Should it be measured metabolically, for example, in the CAT scan, or anatomically by cytoreduction in the CAT scan as compared to the PET scan, which would be the metabolic measure? Does dose response correlate with survival? So far, we don't have any evidence that it does. And finally, what are the molecular determinants that underlie chemoresistance? This is a main thrust of the research program at our institution that Dr. Dina Lev is involved in providing tremendous leadership. Under her leadership, we're hoping to learn more about the molecules causing or accounting for chemoresistance, and therefore potentially be able to develop treatments to abrogate it and render standard chemotherapy more effective. So the bottom line on chemotherapy is that it's highly toxic, it's very expensive, it's most useful as a neoadjuvant. The efficacy is hard to define, and we therefore feel strongly that it should not be used outside of clinical trials. Clearly, we need more and better systemic approaches. Now, in the last little part of my talk, I'd like to focus our attention on retroperitoneal sarcomas, which are a particular challenge for many people in this audience. We're going to look at 4 different surgical questions that are listed here. First of all, let's look at the issue of biopsy. The indications for biopsy in retroperitoneal sarcoma are a differential diagnosis when that cannot be ascertained by history or standard laboratory values, or in order to demonstrate a malignancy that will enable the patient to be enrolled in a neoadjuvant treatment program, to allow screening for definitive non-surgical treatment if the patient is deemed unresectable and has a proven malignant process, to retrieve molecular markers for targeted therapies such as c-KIT status in a retroperitoneal gastrointestinal stromal tumor, to identify heterogeneous areas of the tumor that might require particular approaches, or if the tumor itself is a metastasis from another site. Now, 3 patients that were referred to us just as a random sampling in October of 2005 in our clinic are shown here, and these are their CAT scans, a 45-year-old male, a 55-year-old female, and a 58-year-old male. They were referred as retroperitoneal sarcomas. However, history, physical, and screening laboratory tests determine otherwise. The 45-year-old male has a germ cell tumor, as can be seen from his alpha-fetoprotein levels. The middle panel, the 55-year-old female, has a pleomorphic liposarcoma, and her screening laboratory tests are normal. And the 58-year-old male shown here, that's a lymphoma. LDH was 3 times normal values, elevated beta-2 microglobulin, night sweats, weight loss, so forth. Another area of controversy is the extent of surgical resection. And some of these tumors are deemed unresectable for a variety of reasons. Vascular involvement is particularly ominous, but not vascular involvement in the great vessels, which can almost always be grafted, so much as the visceral vasculature, particularly the venous vasculature. The structure that I'm most concerned about in the retroperitoneum is if a tumor involves superior mesenteric vein for a long segment that can't be reconstructed, because then it's going to be very difficult for the patient to have adequate venous drainage of their gut were we to undertake the resection. Peritoneal implants, such as sarcomatosis, means that this patient's overall prognosis is very limited. Obviously, distant metastases have to govern the extent of how radical you're going to be in the intra-abdominal or retroperitoneal components. Rid of mesentery involvement can sometimes be very, very difficult. In some of these patients, particularly the FAP patients who have desmoids in the root of the mesentery, we work carefully with our vascular or even our microvascular surgeons in order to perform SMA reimplantation if needed. Spinal cord involvement is obviously an issue. And finally, the extent of the disease versus the underlying biology set up a tension in your own experience that has to be accounted for intraoperatively. These are the most difficult decisions that we face, how to balance the question of what anatomy is available and is dispensable and resectable versus the underlying tumor biology per se. A couple of examples can show you the type of dynamic tension that those of us who work in this disease site deal with. This is an easy decision because this patient has a tumor. It's a GIST tumor. It has responded to Gleevec with cytoreduction, and it's located in the left upper quadrant, so a left upper quadrant exoneration will cure this patient. Easy biology in an easy location. This is a little bit more difficult, sort of an intermediate level decision, if you will. This is a well-differentiated liposarcoma, so it's very favorable biology. However, its location isn't particularly good. You can see the great vessels down here in this area, and it's very extensive disease. This is what it looks like intraoperatively. But the well-differentiated liposarcomas are essentially pushing tumors rather than infiltrating, which is why it's a somewhat more favorable situation. And so here we are at the end of the resection, which took all of 2 to 3 hours to perform because there was no infiltration in any critical structures. Now here's an example of a truly difficult problem, an unfavorable histology. This is a malignant fibrous histiocytoma in a very bad location. You can see there's no plane to be had between the tumor and the vertebral body. These 3 little cross-hatchings, that's the vena cava that's plastered to the tumor. This is what it looks like intraoperatively, and you can see the tumor flattening out the cava. This is the resection at the completion, and while it is a gross total excision, this is an infiltrating tumor. It's touched on many critical structures, some of which couldn't be resected, and so the long-term outcome for this patient will be less favorable than the other individuals shown in these vignettes. Finally, the question comes up, does it make any sense to debulk these tumors, to remove some of the tumor in the interest of potentially palliating real or future symptomatology? This has been looked at before. Storm and Mavi, in their meta-analysis a number of years ago published in the Annals of Surgery, compared a large group of patients who either had a debulking partial resection shown by the solid line or no resection in biopsy alone. And you can see at either 5 or 10 years, there's no significant difference in overall survivorship, whereas the patients have been exposed to the potential toxicities of a major tumor resection. So there's a number of controversies in neoadjuvant approaches in this disease. Certainly some potential benefits, immediate treatment of micrometastases at the time of diagnosis, smaller radiation fields, cytoreduction leading to a smaller operation, decreased possibilities of tumor dissemination intraoperatively, enhanced delineation of tumor margins that will enable better radiotherapy targeting to take place, in vivo chemo and radiosensitivity, which will help establish if treatments have been useful and therefore justifiable to be continued in the postoperative setting. And it does allow for the assessment of percentage necrosis that does have prognostic implications. However, there are potential problems in using these neoadjuvant treatment approaches in the retroperitoneum, such as the obliteration of tissue planes, potentially impaired wound healing, which can be particularly important if you're dealing with a bowel anastomosis or bowel biliary anastomosis as part of the resection, other wound complications and serious problems, devascularization of critical structures such as the ureter. Aggressive surgery in combination with radiation can sometimes account for that. The biological, financial, and time costs have to be factored in for the patient. And finally, do these approaches really impact on overall or local recurrence-free survival in this disease? And the answer is we don't have information to so demonstrate. Lots of questions to be studied in this arena. Drugs, which ones? Obviously better ones, but how much and how should these drugs really be used? How to optimize the radiation doses, and should the drugs and the radiotherapy be given concurrently or be given in sequence? And finally, as I alluded to a moment ago, can we develop molecular modifiers of response to improve the situation? Well, I would like to close and just mention that while the pathway to new approaches in soft tissue sarcoma is not clearly marked, it is very clear that by working together, we will make things better. and I appreciate your attention this morning.